So, in the next few minutes, I would like to discuss. I was given a choice of using sequential versus bipolar ablation versus the bipolar ablation. I chose the bipolar ablation mainly because of the fact that the topic is kind of a little bit relevant, and also there is some prelude to what is coming in the future. Although I'm not going to be touching much on that aspect of the next relevant source of ablation, but we'll talk a little bit just to understand why we need to really think about bipolar ablation. So these are my disclosures, nothing relevant to the topic of interest. So when we talk about the intramural ventricular tachycardia, so why do we need to perform bipolar ablation of ventricular arrhythmia? Is a question comes up. In order to know that, we need to understand the substrate of the intramural ventricular tachycardias and how it is being performed. So this is all depends obviously on the reachability of the substrate. That's the main issue where we are dealing with. So this is an example of a patient who is a 79, who was a 79, my patient, year old with sarcoid cardiomyopathy with ventricular tachycardias. As you can see, there is two VTs now denoted in this one. One on the left is a VT1 and the VT2 on the right side. There's some subtle variation. One was exiting to the left and one was exiting to the right side of the scar. So what it means to tell you is the scar was in the septal location, and this was approached by unipolar ablation, sequential unipolar ablation. So not all VTs are approachable by this method. Since I'm going to be talking more on the bipolar aspect, I will tell you why likely sequential unipolar ablation targets you could potentially be achievable. So when the VT substrate is and from the endocardial site is less than 6 millimeters, it seems to be reachable. That's because of the fact that the radio frequency energy can penetrate that much deep. Then the pace or the entrainment with the concealed fusion at the site of ablation could be helpful. The reason is simple, that it is reachable. That means a lot more on the endocardial side it is reachable, where you can actually get the concealed fusion. Number three being the substrate. We have seen time and again, if you can approach a patient from endocardial site, the unipolar voltage shows the emphasis. If you emphasize around 1.5 to 3 millivolt, you actually see the substrate in that particular region. So it seems like that means it's reachable. So all we are all dealing in this case situation is how deep you are basically able to achieve from the endocardial surface. The local fractionation of the diastolic corridor, if it is identifiable endocardially, that also gives you an idea. The substrate is much more reachable from the endocardial target. Hence, the sequential unipolar ablation can be performed. So why bipolar ablation then? So we know that one of the problems, this is a very unusual case, but this is a patient with histoplasmosis. You rarely see that kind of a ventricular scar. Then the other one being a deeper endocardial scar. So why approach in this is a problem? So let's look at the understanding the intramural ventricular tachycardias. So we all know that we talked about it. The substrate is a problem. So one of the things to start with, starting point is identifying these potential substrate. How do we do that? One way is to do an MRI to look at how this pre-procedure. Then PET scans are useful if there is an active inflammation going on, in particularly inflammatory cardiomyopathies type. Although you may or may not consider to ablate in an acute inflammatory phase, at least it is a starting point. At some point, sometimes you may have to take these patients because they have a storm and you cannot control them. Equally important when the MRIs are less feasible is to do a CT scan with a delayed enhancement. It's still a possibility of identifying the potential substrate as well. Now, we started to do one more thing is the VMAP, is the vector medical. It uses the demonstrate the activation patterns. In this case, the activation patterns are seen in both sides of the septum. It's indicative that there is a substrate which is actually exiting in both sides of the VT. Now, we have a paper currently under submission. This is a concept is called the transmural fusion pacing. I called it as transmural fusion pacing for the fact that we actually validated this technique. The pacing, this in order to sometimes, especially hemodynamically unstable VTs, the identification of a critical site for an ablation becomes a challenging issue. So you have a VT present, and can you really demonstrate even with the substrate? Substrate can be big enough, so you cannot really ablate the whole substrate. You may have to target the area of interest. So in this particular patient, the left panel indicates the ventricular tachycardia. The middle panel is showing evidence of a vision wire, in this case, placed in the septal perforator, and it was spaced and validated to demonstrate the similarity of the VT. When you place two catheters on either side of the septum and pace simultaneously, and you develop what is called a transmural fusion pacing. This is similar to what we are seeing in the septal perforator. So even if you don't have a septal perforator available in that particular region, because not all septal perforators are there everywhere, in that case you may be able to validate this. We also tested in different ways. If the morphology is slightly different, you can change the timing between the right side and the left side of the ventricular septum, and you can alter the morphology. If it matches in that area, it will be a good target to consider doing a bipolar ablation. We also looked at it last year, the last HRS. We presented this data on looking at the dominant frequencies, used the fast Fourier transform model, looking at the frequencies. So if you look at, instead of using the peak frequencies, we are using a dominant frequencies in this case. So the low frequency signals scattered around in the area of interest. In this group of patients, the frequency distribution falls more into the lower frequency zone, where these substitute seems to be exiting in that areas. If you see them, I think the substrate we are dealing is much more deeper. So we retrospectively analyzed these patients who have had a successful outcomes using the bipolar ablation. In this case, you can see on the left side, the ablation lesions are present in this region. And if you use the dominant or the low frequency signal, it falls into the same area of interest. And if you look at the isochronal late activation mapping, it falls into this low frequency signals in the same location, and the unipolar voltage in the 5 to 6 millivolt range. So that gives you an idea what you are dealing is a mid-myocardial substrate, and hence targeting those areas with much more powerful tool in the form of a bipolar ablation would be helpful to target those lesions. This is an example of a patient where the ventricular tachycardia, and this is a little bit off scale in the vector map, mainly because of the fact this is a generic CT. They're coming up with a newer patient-specific CT. So in this case, it was showing evidence of a septal ventricular tachycardia, and this was the transmural fusion pacing. The individual pacing was only 75% match, but when you actually do fusion pacing, it's on either side of the septum, it is 93% in this case, and that's where it was targeted. Interestingly enough, even if you move a little bit further out, the VT morphology changes. So you can actually see how precisely you could potentially target that area with a bipolar ablation. If you obviously have a luxury of identifying using a propagation map and the VT is stable enough, you can actually identify the VTs on either side of the septum, and you can actually go to the area of target. Now, another important aspect is also the isochrones. If there is any missing isochrones, which tells you, I think, part of the isochrones may be much more deeper in the substrate, where you can actually potentially target those areas. So how do we improve tissue penetration with ablation lesions? So one way is to change the impedance. So by unipolar ablation, when it fails, you can alter by using many things in the form of half normal saline, even DFW, but the DFW is associated with a lot of tissue pops, but steam pops. But the half normal saline has been extensively used by many ablationists in general. You could increase the number of patches, or even target the patch of the area of interest, like in the anterior wall, for instance, very close to the summit region, where you can target. You can actually lower the impedance much more significantly, so you can actually penetrate the circuit more. So alternatively, you can actually do the bipolar ablation. How do we do the bipolar ablation? By placing the catheters on either side to deliver, so that you can have a transmural lesion. As you can see in this particular case, sequential unipolar still actually has a rim of tissue which cannot penetrate. This was shown by Koruth et al. And as well as the Wilsauer demonstrated the simultaneous versus sequential still leaves an area where you cannot really penetrate, but the bipolar ablation do penetrate this area. So how is bipolar ablation performed? So this is the scheme that we have seen the cartoon, showing evidence of an ablation catheter on one side of the septum, the return or the grounding catheter on the other side of the septum. In this case, it is now the circuit is to the EP mapping system. It should identify once you have identified the circuit, then you actually switch towards the ground, becomes a ground is connected to this area. So you actually penetrate this across the wall with the radio frequency energy. How do we improve the lesion efficacy? One way to do is actually to place the catheter. The return catheter can be 8 millimeters. A bigger electrode or bigger disc actually penetrates the lesion better. And not only the fact that it also does that way, but also lowers the temperature locally. So you can actually improve the efficacy and also reduce the risk of steam pops as well. So one of the problems, I didn't tell you much about this other than the fact that the complications could potentially occur is, the scar itself is sometimes impenetrable with RF. That is something we need to keep that in mind. RF is a somewhat kind of a, it doesn't, it stops like there is an insulation sometimes with a thick scar. Occasionally, particularly valvular heart disease, you see a lot of calcium, so it may be a little bit difficult in that situation as well. One way to monitor this is to look at how much current is driven. That is probably the most effective way of knowing how deep the energy is delivered. Then you can actually see how much is you can actually see the impedance drop along with so that you know definitively how much you're delivering. In this case, the VT is going on, and then the bipolar ablation is done, and within 6 seconds, the VT terminates. That means to say that identification of the lesion where you want to perform is the critical thing before you use the bipolar ablation, and in a very minimalistic fashion, so you don't ablate too much. So the ablation parameters for bipolar is, first of all, identifying the substrate. Then start with a lower power to see you are seeing the impedance drop in the right direction. Then you can increase the power, so you can actually drop the impedance to about 20 to 30 ohms. You see the best effect of transmural ablation. With that in mind, we have a paper currently under submission, which is the bipolar radiofrequency ablation of intraseptal VTs in both non-ischemic and ischemic, a multi-center experience. We have about 67 patients with a 4 years data, so they're probably the biggest, I would say. And these were quite sick patients that we have encountered, and acute success rates were as high as 94%. This is similar to Delabella's non-ischemic 23 patient data that he published some time ago as far as acute success rate is concerned. And there was one AV block and 3 minor complications were seen. And these patients, 8 patients of them died over a period of time. They were sick due to heart failure or worsening heart failure. And overall, the outcome seems to be much better in this group of patients, preventing them from getting admitted because of ventricular tachycardias. So why bipolar ablation may be necessary when the sequential unipolar ablation fails? Then deeper intramural substrate is the reason where we have difficulty to reach using endocardial approach, and the dense scar. Then the substrate identification by the unipolar voltage 5 to 6 millivolt is the area where seems to be the location where the ventricular tachycardia seem to be mapped, and missing isochrones from the endocardial surface, and the dominant frequencies in the area of interest. So what is new in the future? Probably we have done already few cases is the pulse field ablation. I think that's going to be trumping a lot of these technologies to an extent where I think we can, because the scar is pulse field is agnostic to the scar, it actually can penetrate without having to worry as much as we are worrying right now with our radio frequency energy. Thank you so much for your attention.